I'd like to introduce Jill Manning, who will be our presenter today. Jill Manning was born and raised in Camrose, Alberta, and first came to Southern Alberta in 2003 to attend the University of Lethbridge. Jill obtained her Bachelor of Arts in Psychology and has been working in the human services field for the past 13 years in a variety of positions ranging from disability services, youth, domestic violence, and addictions. Jill highly values community involvement and has been an active Rotarian for the past decade, serving as the 2017 and 18 president of the Rotary Club of Lethbridge Urban Spirits. Jill is currently the Managing Director of ARCHES, which stands for AIDS Outreach Community Harm Reduction Education Support Society, and has been with the agency for 3 years, although I know ARCHES has been around since the 80s. So.
Yes.
So I'd like to welcome sites in Pincher Creek, Fort Macleod, Coaldale, Lomond, and Arrowwood. Some of you are joining by video conference and some are joining by Facebook Live, so enjoy the conference. We've heard Jill speak a couple times on this topic and she really knows her stuff and is really involved with opioid issues in communities in Southern Alberta. So take it away, Jill.
Thanks, Robin. Hello, everyone. I am Jill Manning. Thank you so much for having me here today. So today we are discussing opioids, and many of you have probably heard about the current opioid crisis that's happening in Southern Alberta. Certainly that's not specific to Southern Alberta. The opioid crisis is being experienced all across Western Canada as well as the Western United States, and is starting to move over into the eastern provinces as well. So to start off, one of the first big questions that a lot of people have about the opioid crisis is where did this come from and why all of a sudden? Really up until about 5 years ago, there were opioids that were used and certainly that were misused. However, we didn't hear about drugs like fentanyl and carfentanyl and W18, which are some of the things that many of you have likely heard about on the news. So I want to give a little bit of backstory to explain how we got to where we are currently. If we rewind to 2012, here in Canada, what happened was that a longitudinal study was completed leading up to 2012, and in 2012, we got the results of that study. The results of that study showed some fairly alarming things. So the one kind of primary thing that it showed was that when we compared prescribing practices amongst Canadian doctors to prescribing practices around the world, the results showed that Canadian doctors were prescribing opioids at a rate 2.5 times that of anywhere else in the world, which is fairly alarming because really pain is pain. And so Canadian pain is no different than African pain or Asian pain. And so why was it that these opioids were being prescribed at such alarming rates? There were a couple of reasons for that. Number one, there were some incentives being provided from Big Pharma in accordance with doctors' prescribing practices. And then secondly, there was a new drug on the market that was being targeted or being marketed as a non-addictive opioid, which the opioids are known as being quite addictive. And so doctors were prescribing that under that belief. And then it took a number of years to recognize that no, actually, that drug is also just as addictive as other opioids. And that drug was the original form of oxy. So keeping those things in mind, I also want to speak a little bit to the addiction process, not just to drugs and substances, but just addictions in general. So anytime that we formulate an addiction to anything, whether that be to a substance, whether that be to something like online shopping, or to eating, or gambling, or sex, or anything, basically the reason that we form that addiction is because there's a very kind of communicated interplay and feedback system. Whenever we engage in a behavior that we enjoy or that's enjoyable, basically our body releases a natural neurotransmitter called dopamine. And dopamine is kind of like our natural feel-good. It's what gives us that natural high. So when we do something that is great, our body releases this rush of dopamine, we get that natural high, and that's an incentive to participate in that behavior again. The opioids in particularly, when we compare them to other substances and just other behaviors, the opioids are very tricky because the opioids, if you looked at them under a microscope, pharmacologically, the opioids are very similar in structure to dopamine, so to the body's natural feel-good neurotransmitter. And our bodies are nothing if not efficient. And so what ends up happening in either a heavy opioid user or a long-term opioid user is that that person's body starts to not be able to differentiate between dopamine, that natural neurotransmitter, and the opioids. So over time, what can happen is that a person's body, just because it's very efficient, will say, well, if I'm getting this provided to me from an external source, then there's no need for me to continue producing dopamine. Which means that we've seen in some studies that when we look at people who have used opioids, either long-term or quite heavily short-term, when they try and quit cold turkey, so they just try and become abstinent in order to enter their recovery, what happens is their body can take a year to a year and a half before it's able to start producing that dopamine again. Which means that for that year to a year and a half, after a person goes cold turkey off of opioid use, they're unable physiologically to feel good. And so that's important to know when we're talking about addictions kind of services and studies, because typically what we do in case management is we try and find alternate behaviors in order to provide kind of safer highs or more natural highs. And the difficult thing with opioid use is that if someone quits cold turkey and then we try and encourage them to do things like eat really well and get lots of sleep and get exercise, that in a non-opioid user, yes, those things would produce dopamine and those would give you a natural high, but in an opioid user, that's not the case. In an opioid user, regardless of what activities they engage in, they may be physiologically incapable of feeling good for a year to a year and a half. That's one of the reasons why opioids tend to be one of the drugs that have the highest rate of return. So basically, if you're an opioid user and you try and go cold turkey, many studies have showed that that's not particularly effective. So abstinence is not an effective way to maintain recovery from opioids, because one of the reasons that there's such a pull to go back to opioid use is because if you can't feel good any other way for a year to a year and a half, obviously that's a fairly high motivator to go back to your drug use. Other things we need to consider when we look at opioid addiction. So when we look physiologically at what the two hardest substances to come off of are just on your bodily systems. So what gives you the most severe withdrawal symptoms? The two drugs that are the most difficult to come off of are the opioids and alcohol. Both of those substances, when you are withdrawing from them, if it's severe use or extreme use or long-term use, a person can actually experience a fatality when they try to stop taking their opioids or stop using alcohol, because the body just doesn't know how to function without the substance any longer. So that's obviously something that we need to keep in mind when we're looking at people who are entering recovery and who are going through withdrawal. So a much more highly effective way to handle recovery from opioid use is through opioid agonist therapies. So you may have heard about things like methadone and Suboxone. Those are opioid agonist therapies, and it's very similar in ideology to someone who might use like a nicotine patch in order to quit smoking. Basically, any addiction is comprised of both the physiological as well as the psychological component of that addiction. And so if you can only have to tackle one of those things at a time, then your odds of being successful in your recovery are much higher. So for example, some psychological components of addiction would be things like your triggers. So the peers who you usually use that substance with, the places that you use that substance, any activities that you have associated with that substance, whereas some of the physiological kind of components of addiction are more of the kind of biochemistry. So that's where you experience the withdrawal and physiological symptoms of coming off of a substance. So what methadone and Suboxone do, very similarly to a nicotine patch, are that they allow someone to tackle the psychological component of addiction without having to also be going through the physiological component and having the withdrawal symptoms. So originally, or kind of in a perfect world, opioid agonist therapies like methadone and Suboxone are actually intended to only be used for kind of a period of time and then to wean a person off, for lack of a better term. However, we're seeing currently that because the opioids have become so potent, that it's actually much more effective for people to be on those opioid agonist therapies for long-term and sometimes even for life. Now, sometimes people will argue, well, that seems kind of ineffective because someone is still reliant on an opioid. Yes, methadone and Suboxone are in fact opioids. When they're used in the amount that's prescribed or dosed from a pharmacy or a physician, they don't get a person high. So there's no kind of immediate effects or benefits to opioid agonist therapies aside from the fact that they prevent dope sickness. Dope sickness is a very specific term that you may or may not be familiar with. Dope sickness is a term that's specifically used for someone who is experiencing the withdrawal symptoms from opioid use. So if someone goes cold turkey, or if someone isn't on a high enough dose of methadone or Suboxone, then some of the physical symptoms that they may experience are things like extreme flu-like symptoms, so nausea and diarrhea, chills, fevers, insomnia, being unable to sleep but being exhausted all the time, restlessness, bodily pains, headaches, really it's quite nasty. Dope sickness is one of the worst forms of withdrawal that someone can go through, and those short-term can be very, very intense for a week to 2 weeks, but can actually last long-term for a matter of months. That's another reason why people are more likely to go back to opioids, because if you're feeling that awful all the time and you know that the only thing that will help you to ease that discomfort is to use an opioid, then that's another reason why we see that people who are using opioids have a very hard time maintaining their recovery over long periods of time. So, in 2012, to return to where I started, that original study showed that Canadian doctors were prescribing opioids 2.5 times more than anywhere else in the world. It also discovered basically any time that a pill is made, so when we're talking about the original form of oxy, which is an opioid, any time that a pill is made, it's given a rating according to its propensity for abuse. And what that means in layman's terms is how easily that drug is abused or misused in a way that it's not intended to be used. So if you compare, say, like an extra strength Tylenol, that pill, that's like a white powdery pill, and you compare that to, say, an Advil, and the Advil has the red candy coating on it. If you took an extra strength Tylenol and you were to place it underneath, say, a teaspoon or a butter knife, and you were to apply pressure, that extra strength Tylenol is just going to break down into like a powdery substance. That has a very high propensity for abuse, because that powdery substance is then very easily either boiled down to be injected, or it can be snorted or smoked very easily. In opposition to that, if we look at like an Advil that has the red candy coating on it, that has a much lower propensity for abuse, because similarly, if you were to place that under a teaspoon or a butter knife and apply pressure, it doesn't break down into a powder the same way that a Tylenol does. So it breaks down into little chunks. It still certainly can be broken down further to be injected, for example, but it takes more work on the part of the drug user. So if we compare those to the original version of Oxy, the original version of Oxy was a little green pill, and it had the number 80 stamped on it, and it was powdery, like an extra strength Tylenol. So it had a very high propensity for abuse. So in 2012, after those results came out, what Health Canada and the federal government decided to do was to severely restrict or completely eliminate access to that original version of Oxy. So some things we know about addiction. We know that when a person has an addiction, not just to substances, to anything, they develop a tolerance to that either activity or that substance. And so as you develop that tolerance, it takes more and more of the same substance or the same activity to elicit a response in your body. So if someone has built up a tolerance to OxyContin, let's say, that means that even though they may have started taking Oxy according to their doctor's prescription, that if they have kind of acclimatized to that dosage, that they may have to step that up in order to receive the same effect of pain management. So if we compare that, say, to gambling, the same thing may happen, that a person becomes compulsive in any behavior because they need those bigger wins. Users will call it chasing the high. So you have a very difficult time getting the same feeling as you did the first time that you had your big gambling win, or the first time that you experienced a high from substance use. And so that can definitely be one thing that leads into compulsive or addictive behaviors. Additionally to that, with the opioids specifically, because we have seen, so just in kind of like basic knowledge, that at the bottom of the kind of opioid spectrum, when we look in terms of potency, we have codeine. So codeine is found in Tylenol 3s or in cough syrups, can be purchased over the counter sometimes. From codeine, when you move up, then you move into some harder pharmaceuticals, so things like Oxys and Percocets, and keep in mind that all of the opioids are really good at pain management. They're the most effective pain management that really we can consume as humans. So once we get above Oxys and Percocets, some of those pharmaceutically prescribed opioids, then we start getting into heroin. Heroin's kind of the next step up in terms of potency. Equivalent to heroin is morphine. Many people don't realize that, but similarly to how if you looked at dopamine under a microscope and compared it to an opioid, they would look very similar. Heroin and morphine, for all intents and purposes, are very, very similar drugs. So heroin 5 years ago was kind of the big daddy of drug use. That was what people thought of if you were a hardcore drug user. Likely you were a heroin user, particularly injection heroin use. That was kind of seen as the pinnacle. So how over the course of 5 years, and really when we look for decades prior to about 5 years ago, decades prior to that, anywhere in North America, heroin was certainly abused, but we didn't see things like fentanyl and carfentanyl. So what happened in 2012 when they made it much more difficult for people to get their hands on Oxy, and some people, keep in mind, may have been using Oxy kind of legitimately through their doctor's prescription, and some may have been purchasing on the streets. So once that became much more difficult to get, we know supply and demand. So when we have a supply that has shriveled up and we still have demand, we know the price goes up through the roof. The first population that can't afford that are homeless and street-involved people. Excuse me. So keeping all this in mind, in the drug kind of services community, in the addiction services community, what we anticipated would happen was that because people couldn't get their oxy anymore, we anticipated that we would see a spike in heroin usage. Because we also know that due to that buildup of tolerance, if I say I'm someone who uses oxy and I can no longer get my oxy, I can't return to using codeine because codeine isn't as high a potency and so it won't scratch that itch for me. So I need to find a replacement opioid that is either the same or greater potency in order to kind of meet my needs. So we thought we would see this huge uptick in heroin usage. We didn't see that for a couple of reasons. Number one, heroin is very expensive. People, because we have been using heroin in Western civilizations for decades and decades, people have gotten very good at detecting heroin. So police services, border crossings, customs, all of those folks basically know what to look for when they're looking for packages of heroin. Drug dogs can detect heroin. So because it's hard to get across borders, it drives the price up. Again, supply and demand. So drug dealers and drug producers, for their faults, are actually fairly resourceful, intelligent people. So they recognized that they had this whole market of people who were looking for a replacement opioid from their oxy they could no longer get. And they thought, okay, it's too dangerous and risky for me to start importing heroin in great kind of amounts. And so instead they turned to fentanyl. Fentanyl, from a drug dealer or a drug producer's perspective, it's a dream. It's a perfect dream. And the reasons for that are because, number one, it's dirt cheap. And please don't, but any one of us could go online right now, and if we just Googled purchase fentanyl China, you would be able to find a website that would facilitate that. It's very easy to find, and it's very easy to purchase. In terms of price, about the equivalent of $12,500 American, so in US dollars, that will purchase you enough fentanyl to produce about 1 million pills. And right now on the streets, fentanyl is selling for about $30 to $40 per tablet. So that means an investment of $12,500 could garner someone profits of anywhere from $30 to $40 million. And that can happen as quickly as within 6 months. So there's big money to be made in fentanyl production. Secondly, fentanyl is tasteless, colorless, and odorless. I can see some of your reactions there to that. It is really quite alarming. Like, wow, there you can understand, and that's not to justify drug dealing, but you can understand why it might be that someone who had limited opportunities or felt that they didn't have the ability to enter other lines of work, that might be a fairly strong incentive for someone to enter that field. So on top of that, fentanyl is tasteless, colorless, and odorless, which means that it's very difficult to detect when it's crossing borders. And because it's so concentrated, so when we compare in terms of potency, fentanyl to heroin, fentanyl is estimated to be about 100 times more potent than heroin is. So it's much more potent, which means that just because it's so concentrated, you can order the same number. So if I'm ordering, say, 1,000 hits of heroin, the packaging is going to be much larger than the equivalent number. So 1,000 hits of fentanyl is going to be able to be packaged much more concentrated because the drug is so much more concentrated. And typically speaking, Border Patrol and Customs have focused on larger packaging because obviously you get more bang for your buck. But now in today's world, because fentanyl can come in quite small packages, for many years, it was just kind of sneaking through the border undetected. Drug dogs also can't detect fentanyl because it's tasteless, colorless, and odorless. They are starting to be able to, but it's definitely not an exact science. So from a drug dealer's perspective, fentanyl is a dream. I also forgot to say, typically it's ordered from China, so fentanyl comes raw, unprocessed, and when ordered from China, if it's detected en route to whoever has ordered it, China will guarantee reshipment until the recipient receives it. So, and that's unheard of in the drug world. So they will resend if it gets detected at no charge to the purchaser. So really, from a drug dealer, drug producer's perspective, you can understand why this would be a drug that people are drawn towards. So what we expected when Oxy was pulled off the market is that we'd see this uptick in heroin. We didn't. Instead, what happened is that people purchased all of this fentanyl from China, raw, unprocessed fentanyl. Like I said, when it is in its unprocessed form, it's just a kind of looks like a white powder. Obviously, because the potency of fentanyl is so high, you may or may not have heard, the equivalent of 2 grains of salt of raw, unprocessed fentanyl is enough to elicit a fatal overdose in someone who has no tolerance built up to opioids. So in a non-opioid user, if 2 grains of salt of fentanyl, me as a non-opioid user, were placed on my tongue, that would potentially be enough to induce a fatal overdose. So that would be enough to kill me. So obviously when someone uses a tab of fentanyl or a pill of fentanyl, that pill is not all fentanyl, because if it were, it would be enough to kill anyone. So instead what happens is that drug producers, they order this powder and then they put it into a mixing bowl, and there's 6 other substances that are commonly used in the processing of a fentanyl pill. So they put it in, like, many times just a mix master, like you would use to bake chocolate chip cookies, and they mix it all together, and then they put it through a press, they dye it green, and they put it through a pill press, and they stamp the number 80 on it. And if you remember when I was describing what the original version of Oxy looked like, it was a little green pill that was powdery in nature, and it had the number 80 stamped on it. That's exactly what fentanyl pills look like, and that's not by accident. Nowadays, people have realized, because it's been a number of years, that that's not actually Oxy, the original form. But when it first hit the markets, people thought that they were buying Oxy, and they thought that they were buying it from they knew they were buying it off the streets, but they thought that it had been produced pharmaceutically. So when you are taking Oxy from, that's been produced pharmaceutically, you can guarantee that every pill has the same dosage. And let's say that I was a soccer mom who had been in a car accident in 2009, and I was prescribed Oxy, and I'm taking that, and I've built up a tolerance, so I start to abuse it and misuse it. And so now I'm to the point where I can take 2 Oxy 3 times a day, and that just kind of keeps me on an even keel, and that manages my pain. And so then all of a sudden I can't get my Oxy anymore, so I go to the streets, and I know that I'm buying what I think is Oxy off the black market, and so then I get those. They're actually fentanyl, and I take 2 of those because that's the dosage that I'm used to. And if I luck out and I get 2 fentanyl pills that happen to not have any grains of fentanyl in them, then okay. And if I happen to, it's like Russian roulette. If I happen to get 2 pills that have 8 grains of fentanyl in them, then obviously I'm going to experience a fatality. So, and still to this day, that's how fentanyl pills are made. It's very dangerous because we always use the analogy of that if you're baking a batch of chocolate chip cookies, it's very difficult to ensure that they're the same number of chocolate chips. So if I'm trying to make a batch of chocolate chip cookies with 5 chocolate chips in each cookie, that's very difficult for me, and I can see the chocolate chips. If we compare that to making a pill of fentanyl, they can't see the fentanyl in it, and it's just impossible for them to have any consistency from one tab to the next. So even for a seasoned drug user or someone who's been using drugs for a long period of time or heavily, they may think, okay, well, last time I used 1 pill and I didn't really feel anything from it, so next time I'm going to use 2. But depending on the potency of the pill that they received, so it's really a guessing game. One of the things that we do at the supervised consumption facility in order to combat that is that we recommend that people use small doses, even if they have to repeat those small doses, just so that we can ensure that we know what we're dealing with, rather than having someone overdose because this pill that they got is drastically stronger than the pill that they were doing yesterday. So we started to see overdoses in 2013. The rates in BC started to go through the roof. And that's simply because that's the natural port of entry when things are arriving from China. So we should have been more prepared, honestly, here in Alberta. We should have known that there's no invisible force field over the mountains and that the drugs that are in BC will eventually permeate over into other areas of Canada. Unfortunately, we weren't as well prepared as we could have been. One of the ways that we tried to be prepared was through the take-home naloxone kits, and I will be providing a tutorial on how to administer take-home naloxone after we finish our main presentation here. But the take-home naloxone kits, if you spoke to someone who works in EMS or in an emergency room in a hospital, and you asked them prior to 4 or 5 years ago, how often were you finding yourself administering naloxone, they would say maybe twice a year. And if you were to ask them today, they would say numerous times a day. So naloxone is the drug that will reverse the effects of an opioid overdose, and now it has become very commonplace. It's free to the public. The naloxone kits, when Alberta Health originally started putting them out, had 2 vials of naloxone in them. They've now increased that to 3 vials, and because the thinking is that as drugs have increased in potency, it takes more naloxone to reverse the overdose. However, the drugs are so potent now that we're seeing, again, at supervised consumption, we're hearing anecdotally from people who use drugs, as well as through EMS, that it's taking anywhere from 6, 8, 13 vials of naloxone in order to reduce an overdose. So we're having to give away or distribute numerous naloxone kits at one time if people are using outside of safe facilities like supervised consumption, because we want them to be prepared in order to reverse overdoses if they happen at home, in their bedrooms, that sort of thing. So that's how we got to where we are. Now, when we look at how carfentanyl came onto the scene, we have a fairly clear explanation of that as well. So when I was talking earlier in terms of potency, we had codeine, and then we had some of the prescription pharmaceuticals, things like Oxy and Percocet. When we go higher than that, it was heroin and morphine. Higher than that, 100 times more potent than that, is fentanyl. If we compare potency from fentanyl to carfentanyl, it's another 100-time differential. So we have heroin, 100 times stronger is fentanyl, 100 times stronger than that is carfentanyl. Carfentanyl is used for pain management, but it's not intended for human consumption. Fentanyl is. Fentanyl is the highest level pain manager that's available for human consumption. Fentanyl is used in cases of extreme pain, so things like having limbs blown off in war or third-degree burns all over your body. In some pregnancies, fentanyl is administered. When we look at carfentanyl, it's not intended for human consumption, never has been. It is, however, used in animal studies. Carfentanyl is used for pain management and sedation purposes in the largest organisms on the planet. So things like whales and elephants, it is not intended for human consumption. Carfentanyl is so strong that it's typically sold already in an aqueous solution. So what they'll do is they'll take kind of the powder and they'll take one granule of the powder, one little grain of salt, and that one little grain of salt is so potent that when it's boiled down into an aqueous solution or liquid form, it's so potent that that is enough to produce 100 human doses. So when you think about the margin of error in the production of some of these drugs, it's just incredibly small. Carfentanyl flooded the market about 2 years ago. So how that happened was in 2016, so 4 years after the removal of Oxy from the market, in 2016, and in recognition that we had an opioid crisis due to fentanyl, the federal government and Health Canada made it much more difficult for your average layperson to get their hands onto those other 6 substances that are commonly used in the processing of a fentanyl pill. And so what that did, again, is if the supply shrinks up and the demand doesn't change, then the price of fentanyl skyrocketed. So again, we have people who are now looking for a replacement opioid that has to be the same level of potency or higher in order to scratch their itch. Well, if fentanyl is the most potent painkiller intended for human consumption, then where do people go from there? They go to animal studies. So carfentanyl started to be used as a result of kind of the inability for people to get their hands on fentanyl. And carfentanyl we hadn't really seen a lot of in southern Alberta. Just as some background, anytime that the police do a bust, so anytime that they say, you know, go into a flop house or whatever, or they stop a car on the side of the road, if they seize drugs and they do a bust, then they send about 1/3 of whatever they seize off to Health Canada to be tested, just so that we can stay abreast of what the current drug trends are, what's out there, what people are using, and where things are popping up. We weren't seeing carfentanyl pop up in any regularity in southern Alberta until about a year ago. Year and a half, I suppose now. So the summer of 2017 is when it started. We started to say, okay, carfentanyl is here, and since then it's continued to kind of sporadically pop up in various locations throughout southern Alberta. So certainly it is something that we're dealing with. It's very tricky because at the supervised consumption facility, we don't have the ability to drug test. And the reasoning for that is that the government, when we applied for our application, wasn't able to produce the funds for that. They couldn't provide, because a mass spectrometer costs anywhere from $100,000 to $150,000. That's the only really reliable way to complete drug testing. And so as a not-for-profit, we at ARCHES were not able to finance that. And likely, community fundraising wouldn't have been very successful if it was in order to buy a drug testing apparatus. But the result of not having drug testing apparatus is that really we just have to take clients at what their best guess is as to what they're using. So when a drug user comes in and they indicate what product they will be using in our facility, we just kind of have to go with that and guess. Many times, most times, the majority of times, Drug users, people who use drugs, they don't know what they're using. They know what they've been told that they have purchased from their drug dealer. Their drug dealer may not even be their drug producer. So many times dealers don't even know what it is that they're selling. So like I say, right now it's a very scary time in terms of drug use because it really is Russian roulette. You don't know what you're getting, and even if you know what you're getting, you don't know what the dose is going to be, and it's certainly not consistent from one batch to the next. So that's how we got to where we are. When we look at things like recovery and treatment, the kind of typical model that we have long adhered to in North America is that someone would enter detox for a week, and then after that detox, that's kind of where a person gets clean. I don't love that language because the opposite of clean is dirty, and then the connotation is that someone is dirty if they're not clean. However, if someone's entering recovery, they may enter detox and they are abstinent for that 1 week period. The intention of that is to go through the most severe withdrawal symptoms and then to go immediately from detox into a 28-day residential treatment facility where you would do more intensive counseling and focus more on rehabilitation. However, right now our resources are spread so thin in southern Alberta that until very recently, until November, so just 2.5 months ago, the closest detox facility to Lethbridge, really one of the only ones in southern Alberta, was Foothills. So that's in Fort Macleod. They do an amazing job, but they're so overwhelmed that they were operating on a 4 to 6 week wait list. So what that means is that if I'm someone who's interested in entering detox, I have to fill out that application, I have to send it off to the detox facility, I then have to call every 24 hours in order to continually assert my interest, because if they're operating on that large of a wait list, they can't just hold a bed for you forever if they haven't heard from you. So I have to call every 24 hours and assert my interest, and then eventually when I'm successful and I call and they say, yeah, Jill, we have a bed for you, I have to get there within 48 hours. So you can understand that for anyone, that's a bit of a burden. That's a difficult process. Particularly if you're homeless or street involved, that's asking a lot of someone to be able to have the wherewithal to call daily and then to be able to get there when they don't have transportation. So let's say in a perfect world, someone does. They get to detox, they do their week, they're successful and they've entered recovery and they're abstinent for that week. Ideally, they should then be able to go immediately into treatment. That's also not happening because treatment facilities are so overburdened right now. So what's happening typically is that someone finishes their detox and then they're released back to their natural environment. That may be, if you're homeless or street involved, living under a bridge, staying at the shelter, being surrounded by people who are also using drugs, that psychological component of addiction that I talked about earlier, those triggers, being around your same peers and the same places and the same activities that you've so long associated with your drug use, you now are released back into that environment. You then are put on a waiting list to get into a treatment facility, and it may take 4 to 6 weeks until they have a bed for you. So again, I get the call that, yes, there's a bed now for me. I get there and I get drug tested. So if I haven't been successful in maintaining my abstinence post-detox, then that means that I failed the drug test, I'm not eligible for treatment, and I have to start that process all over again. So you can see how that, even in a perfect world, if you could go straight from one to the other, it may be more effective for non-opioid users. The statistics show that success rates and success post-treatment is measured by what percentage of people who use drugs or people who use substances are able to maintain their abstinence for 1 year post the end of their treatment date. And in non-opioid users, so someone who's an alcohol user or someone who uses meth, let's say, or cocaine, the success rates are about 17%, so that's 1-7. About 17% of people who are non-opioid users are able to maintain their abstinence 1 year post-treatment. However, when we compare that to opioid users, if they just go through that traditional kind of detox and treatment, and this is when they are able to do it in a perfect world and go straight from one to the other, the success rates are about 3%. So only about 3% of opioid users are able to maintain their abstinence after getting through detox and treatment, assuming that they're not on any opioid agonist therapies. So we do know that opioid agonist therapies are much more effective, so methadone and Suboxone. The issues with methadone and Suboxone are that, number one, you have to go in daily to get your dosing. Because even though methadone and Suboxone won't get you high, so you might think, okay, well, if they don't get you high, then there can't be much of a street value attached to those drugs because who really wants them? However, and that's true of most things that don't get you high, however, methadone and Suboxone are unique because they still do have quite a high street value. I apologize because this is fairly gross, but we've heard of cases where people have gone in and they've taken their dosage in pharmacy. It's an oral dosage and has to be taken daily, and then they have swallowed it, and they do mouth checks after the person has consumed those. And so if I'm the person, I take my methadone or my Suboxone, I have my mouth check done, I swallowed it, I then leave the pharmacy and I vomit up my methadone or my Suboxone in order to sell it to someone else who will then consume it, because even though it doesn't get them high, it prevents their dope sickness. It stops them from feeling like garbage all the time. So that's how bad the withdrawal is that people are that desperate and will go to those extremes in order to prevent it. So, to be on methadone or Suboxone, I have to have a doctor's appointment and I have to have an intake assessment done and receive a prescription. Now, we do have 2 methadone Suboxone clinics in town in Lethbridge here, but if you're not accessing those, many people just think, okay, go to your GP and get help with an addiction. But you have to recognize that there are many people in our societies who don't have GPs. Many newcomers to Canada, anyone who's homeless or street involved. Oftentimes people who struggle with addiction have burned bridges when they go to doctor's appointments because they may get kicked out because they're intoxicated either by drugs or alcohol, and then they're blackballed, so they're kind of listed on they're no longer able to be clients at that clinic, and if they go through that process with a number of clinics and doctors, then they burn their bridges and they have no further options. So it can be very difficult for someone to get on methadone or Suboxone in the first place, and then once they're on it, to go into pharmacy every day and have to get your dosage and your prescription is obviously quite burdensome as well for any of us, let alone someone who doesn't have transportation, doesn't keep a day timer, have a watch, have a cell phone, those sorts of things. So that's how we got to where we are. When we look in terms of statistics, because sometimes people hear opioid crisis and they scoff at it. Also, we don't want to kind of minimize the effects of other drugs. Certainly there are other drugs that are rampant in our societies. Meth, you've probably heard a lot about, particularly police have been speaking a lot about meth crisis and that we need to not be focused solely on opioids. Agreed, 100%. However, it's not that meth is being used more than opioids, at least not according to the individuals that are using at the supervised consumption facility and the data and stats that we have. So meth is second to the opioid family. However, meth from a behavior management perspective is much more difficult. If you're using opioids, they're a depressant. And so what you'll do after you get high is oftentimes they call it going on the nod. So you're just kind of like in and out of consciousness and you're very relaxed and chill. You're not out, stripping your clothes and wandering around the streets and jumping on cars and that sort of thing. That's not an opioid user. Meth users, however, it's a stimulant and it causes things like induced psychoses and paranoia and that sort of thing. And so from the police's perspective, they're probably seeing more meth users because the behavior management is more difficult. However, we do know that opioids are A, used more often, and B, causing much more damage from the loss of life perspective. So when we look at stats from Alberta Health, and people are oftentimes confused by our systems. So Alberta Health is the provincial body that kind of governs and regulates and makes decisions on where our healthcare dollars go as a province, because healthcare is mandated provincially in Canada. So Alberta Health is kind of the big body at the top, and they figure out where our healthcare dollars are allocated to. Alberta Health Services is the operational arm of Alberta Health. So they receive the majority of funding from Alberta Health, and they provide the majority of healthcare services in our province. However, there are some healthcare dollars that are allocated to other institutions or organizations like ARCHES as a not-for-profit to provide other healthcare services. So Alberta Health collects all of our healthcare data. So what that means is that we have all these different bodies, some Alberta Health Services, some not-for-profits like ourselves, some private, and that those all have to funnel their data back up to Alberta Health. So Alberta Health collates all that data, and they release that data quarterly. So, and anyone can access this data when it comes to the opioid crisis. If you just Google opioid abuse and misuse report Alberta, you'll be able to find some of the data and the statistics that I'm going to share with you today. But generally what we've seen is that year over year, from 2014 till now in 2019, we've seen just about a double, fairly steady increase, fairly predictable, that year over year we've seen a double in terms of fatalities that have been experienced due to opioid abuse and misuse. So what that looks like now in Alberta is that opioids have become the leading cause of death in our province, which is fairly unheard of. For decades, the 3 leading causes of death in Alberta have been some combination of either motor vehicular accidents, suicides, and homicides. And now we're at the point in our province where opioid overdoses are killing more people than those other 3 causes combined. So certainly we are at crisis level, and I know sometimes people scoff at that and say, is this really a crisis? It is. This is the largest scale public health crisis that we have faced as a Western civilization really since the Black Plague. We're losing more people than we did at the height of the HIV/AIDS epidemic in the 1980s. So it's a tricky thing though, because people oftentimes don't hear the actual stories, because very similar to suicide, there's such shame and stigmatization around drug use that if someone passes away as a result of an overdose, it oftentimes isn't reported that way. And so people may think, oh, this is something that only happens to homeless people or to Indigenous people or to street-involved people or to this, that, or the other. Very similar to in the 1980s when people said the HIV epidemic, this is something that only happens to gay men. So we see a lot of that similar stigmatization and further marginalization of already vulnerable populations. The data shows us from 2017, 18, and so far for 2019, we've seen that in both Edmonton and Calgary, and Alberta Health only releases community-specific data for Edmonton and Calgary, because the thinking is that in a smaller community, that the anonymity is lacked that is required in order to reveal that data. So for example, if you live in Tabor or Cardston or wherever, and Alberta Health releases that 7 people died of overdose last year, it may not take long for that community to start pointing fingers and speculating, and then rumors spread about, oh, I bet that person died of an overdose. Whereas in Edmonton and Calgary, the sentiment is that the population is large enough to buffer that. So in both Edmonton and Calgary, in 2016, 17, 18, and so far in 2019, we actually saw that in those communities, the majority of overdose fatalities that were related to opioids were not happening in the downtown core. They were not happening in the slums. They were happening in the suburbs. These are middle to upper class, primarily white communities, and that's who's dying of opioid overdose. And the reason for that isn't necessarily that those people are using the drugs more often or more heavily, it's that they're using them less safely. They're using them, again, because of the stigmatization and shaming of drug use, they're not willing to come to a supervised consumption facility because they don't want to be identified as a drug user. And so instead, they become isolated and shamed, and they put that underground and they hide it, and they use in their car or in their bedroom or in their basement, and then if and when they experience an overdose, there's no one there to revive them. There's no one there to resuscitate them. So a big part of harm reduction is about educating people that if you are going to use safely. Because, and I realize that people think that that sounds like we're enabling folks to, or that we're encouraging folks to use. That's certainly not the case. Harm reduction is very much based on the tenet of that people are able to make their own decisions, whether we agree with them or not, and that whether we like them or not, there are certain behaviors that have always existed socially and that likely will always exist socially. The kind of war on drugs mentality that we have adhered to as a civilization for the last 100 years or so, where, you know, prohibition of drugs, drugs are bad, anyone who uses drugs will become addicted to drugs. We've seen that that hasn't been particularly successful. We haven't really done anything in terms of lessening drug use. Like I say, we're experiencing crises level that we've never seen before. So there does come a point where I think anyone has to ask, it's sort of like that old definition of insanity where, you know, you continue to make the same behavior and expect a different result. And so there does become a point where we have to examine that and say, if what we're doing isn't working, what can we try? Harm reduction is an alternative. Harm reduction is very much about accepting where a person's at and not judging and not blaming and not trying to have the focus on you have to get clean in order to provide or in order to receive supports. It's about trying to have relationships with people that are based on a foundation of trust. On that note, there's a couple of really interesting studies that I want to chat with you about, and I'll just do this quickly and then allow for a question period if we have folks that would like to ask some questions. The way that we have traditionally studied addictions as a Western civilization is by using rats. And the reason that we use rats is because their biochemistry and their brain structure is very similar to humans. And so what we've typically done is we take these rats and we put them in individual cages, and then we put those cages all in a very sterile, fluorescent lighted laboratory space. And on each of those cages, we attach one water bottle that's just water and one water bottle that is contaminated with some sort of addictive substance. What those studies have shown, kind of without fail, is that eventually the rats will begin to exhibit like compulsive behaviors towards the contaminated water, whereby they will go back to it and eventually form what we would call addiction, and that they will do so to the point of experiencing overdose and in some cases fatalities. So that has led to the belief that the drug is bad, the prohibition war on drugs mentality, that, you know, given the opportunity, anyone will develop these patterns. The issue with that is that we know that it's not true. We know that there are many people who are able to be on prescription opioids, people who are on morphine in hospital, and the morphine-heroin kind of dichotomy is very interesting as well, because if we look at morphine, many people are on morphine for extended periods of stay in hospital through an IV drip, whereas we have this kind of notion, and in many cases this is true, that with heroin users, particularly if they're homeless or street involved, that if they use heroin once, they'll be hooked for life. And we do sometimes see that. Well, if the drug is the same, then it's not the drug, it's the human, right? We need to look at the individual factors which lead towards addiction, and those are the protective and risk factors that now have been well identified for years as to putting someone at a higher risk for developing compulsive, dependent, addiction-type behaviors. So recognizing that, finally somebody said, well, let's look at this differently. Let's study this differently. So what they've done instead now, there's a researcher in the late 80s who created what he called rat parks. And rat parks were basically these giant cages and multiple rats in them. So they had social structure, and they had families, and they had exercise wheels. They were able to have sex. They had trapeze. They had food. So really it was like rat heaven. If you were a rat, you wanted to live in Rat Park. And what they saw after studying Rat Park, same setup. So bottles that were just water and bottles that were attached to the cage that were contaminated with a substance. What they saw in Rat Park that was over 5 years, not a single rat in Rat Park developed what we would characterize as a dependency or an addiction. Not a single rat overdosed, and not a single rat experienced a fatality. And some rats still used, some rats still seem to enjoy the experience of using the contaminated water bottle, very similarly to that many people in our current societies, enjoy recreational, whatever you want to call it, drug use. But the fact that not a single rat developed an addiction, dependency, overdosed, or died has really changed the way that we look at drug use and addiction. So in the past, it was that the opposite of addiction is sobriety. And we no longer adhere to that mentality in the addiction services community. So now the thinking is that the opposite of addiction is not sobriety, the opposite of addiction is connection. Because people who are well connected and have supports and have opportunities and have skills and feel like something that belongs to them. I'm a really great hockey player or a great artist or whatever. They have people in their lives who care about them. Those are all protective factors for addiction, and we don't see particularly hard street drug addiction. We don't see very often for someone who doesn't fit the bill of isolation, very few social supports, very few family supports, limited education, lack of opportunity, criminal justice history. So once someone has a criminal record, good luck finding employment after that. Even McDonald's won't hire you if you have a criminal record. So we do all these things that further isolate people, and then we expect them to be able to enter recovery from their addiction, when in fact what people need is to be more connected to their communities in order to strengthen those protective factors and minimize those risk factors. I get a little bit irked when people talk about, I was sexually abused as a child and I never developed an addiction. I apologize that you have experienced that, and it's great that you haven't had that experience of addiction. But also we have to keep in mind that yes, while you have that risk factor, you may have had more protective factors. You may have had a parent or a grandmother or a coach who cared about you and invested their time in you. You may not be illiterate. You may have skills, those sorts of things. And then lastly, before we end and go to question period, I just think it's really interesting as a society, the way that we kind of deal with addiction, specifically to substances and not to other things. Because as a society, we're fairly unhealthy these days. We have electronic addictions, we have addictions to food. Actually, weight mismanagement and obesity have become the two leading kind of drains financially on our healthcare system. It always had been cigarette smoking, and we've now surpassed that with weight management or weight mismanagement and obesity. When we look at someone who has, food compulsive eating behaviors, we don't deny that person their triple bypass surgery when they experience a heart attack due to their weight mismanagement. When we look at a cigarette smoker, we don't deny them their chemotherapy when they are diagnosed with cancer. When we look at someone even who goes snowmobiling in off-country and causes an avalanche, we don't deny them their $2 million rescue effort because they made that choice. So it's very interesting to me that as a society, we have somehow, because the person is a drug user, there's such a widespread sentiment that, well, they made that choice, so they get to sleep in that, they made that bed, they can now sleep in it. And that, the 3-strike rule, that if they've been revived twice after an overdose, we should just let them die the third time. And that can be very, very easy for people to say if they've never experienced addiction or no one in their family has experienced addiction. but I give 3 or 4 of these presentations a week, and when I ask the audience, you know, for parents, how many of you have children, and would you rather that your child be a substance user, or would you rather that your child was dead? And I've never had a parent tell me that they wish that their child were dead rather than being a substance user, because dead people can't get better. Dead people can't make different choices. And so keeping people alive and supporting them through that, no matter how many times it takes, if you're that drug user's mother or sibling or child, there is no amount of times where you say just give up on someone. And really that's what harm reduction is about. It's that you may not be ready to make your choice right now, but we're here to support you regardless, because we recognize that with those relationships and trust, you're much more likely, if you do want help one day, to come to us for that help than if you don't have that relationship at all in your life. So that's the bulk of the presentation. If people have questions, do we know if there are any questions? Is there a way for us to tell? You can ask anything. I've heard it all.
I have a question from the Chinook Arch floor. Well, it's more a comment, Jill. Thank you once again for an amazing presentation. Could you speak to the rate of visitation with the Lethbridge facility? I think that would be some eye-opening information and help people think of questions at our remote sites.
Yeah, absolutely. I didn't want to focus too much on Lethbridge because I recognize that with our rural communities, I didn't want to make it specific to Lethbridge. But I do think it's very valid because there is this perception that, oh, we have it worse in Southern Alberta than anywhere else. We are leading in some pretty dire statistics in Southern Alberta, but we also aren't in some. So, excuse me, we do have some unique challenges, certainly in Southern Alberta. One of the things that is the most shocking to people is when we compare the rate of usage of our supervised consumption facility in Lethbridge to other sometimes major centers that are much larger, like Edmonton and Calgary are 10 times the size of Lethbridge. For comparison's sake, Calgary specifically, it took Calgary 5.5 months to hit 10,000 visits, and in the months of October, November, and December, we were experiencing 20,000 visits a month. So in Calgary, it took 5.5 months to hit 10,000 visits, and we're seeing 20,000 visits a month for the past 3 months worth of data. So it really is alarming. We certainly weren't prepared for it. Keep in mind that that doesn't mean 20,000 different people. That means 20,000 visits from sometimes the same people. So on a monthly basis, we're averaging right around 450 clients per month. So that's 450 unique users who, when they're repeatedly accessing the facility, are using a combined total of around 20,000, just shy of 20,000 times in any given month. We do record all of our other, so we provide referrals to treatment, and we've just recently, actually in the middle of December, been able to implement an opioid agonist therapy referral process, and so we can do it right on site. When we first opened the facility, we had considered implementing that service of being able to provide opioid agonist therapies, methadone and Suboxone, and we had consciously made the decision not to, because the thinking was that if you're someone who is trying not to engage in drug use, if you're trying to be abstinent and you're in recovery, to have you come to a facility where there's active drug use taking place can be hugely triggering for people. So originally we had intentionally not. However, now we have implemented that service. We've been very fortunate and need to express gratitude to Alberta Health Services based out of Edmonton. There's a doctor there, Dr. Day, and Dr. Day has a passion for this population and is compassionate towards them. And so we have a telehealth process where if a client comes into our facility and says, I'm sick of this, I'd like to get off of whatever I'm using, can you guys hook me up with methadone or Suboxone? Then we can do a teleconference intake with a doctor who's based out of either Ponoka or Edmonton, and they can prescribe the drug, and then we have staff who can walk the person to the pharmacy so that they can actually get the prescription on a daily basis at the pharmacy. So that's been huge, and even just since the middle of December, we've had 13 people who use drugs who have been hooked up with methadone or Suboxone that likely wouldn't have if they weren't able to access them through ARCHES. So those of you who are interested in receiving the run-through, the kind of short and quick and dirty version of how to administer take-home naloxone, please do stick around. These kits are accessible through most pharmacies and through any harm reduction agency like ARCHES. So in the kit, is it possible for us to change the view so now I can see myself?
Sure, I can do that.
Because then I can get close enough like that I can make sure they can see my little vials. Okay. So your take-home naloxone kit just comes in a package like this. It's fairly discreet. It does have the naloxone labeling on the front of it here. Some important things to note about your kit is that your naloxone kit is marked with an expiration date because the vials do expire. The medication does have a shelf life. That's marked both on the outside of your naloxone kit as well as on each individual vial. So the vials that are in your kit, like I said, they're now providing 3 vials of naloxone, and they are administered through injection but intramuscularly. Injection can sound really intimidating to people because they hear injection and they think, oh gosh, now I've got to find a vein and I don't have any experience with needles. That's okay. It's fairly user-friendly. It comes with 3 syringes as well, so the idea is that you would use a different syringe with each vial. So you're going to use a new syringe each time. Even though you're using it in the same person, so it's not contaminated with like multiple kind of sources, it's no longer sterile after you've used it once. So other things that are in your kit, you have gloves. Please wear your gloves. I don't care if it is your brother or your spouse or your mom. Wear your gloves. It's for your own protection. So anytime that you're administering first aid skills, you should be wearing your gloves. While I'm putting these on, I should mention that the administration of naloxone is covered in the Good Samaritan Act. So very similar to that if you came across a car accident on the side of the road and you administered first aid, so long as you have the training and you use it according to your training, even if that causes some sort of, if there's negative consequences of that, you can't be criminally charged as long as you have received the training and are using it appropriately. So in your kit, you have your gloves. You want to put your gloves on. Really important part of your kit, there's always going to be this little pamphlet in your kit. Most of the reading, I mean, if you just want a refresher, the reading is great in terms of what opioids are, what an overdose can look like. I suppose I should cover that for you. I haven't yet. Basically, because the opioids are a depressant, what they do is they depress your central nervous system. So what that means is that an overdose from an opioid or any of the depressants, so even alcohol, that sort of thing, they'll all look similar, and what eventually will happen is that a person loses the connection of oxygen to their brain. As you lose the ability to control your muscles through your central nervous system, your diaphragm will be the last muscle to shut down. Once your diaphragm shuts down, then you are no longer able to breathe, and obviously you aren't receiving oxygen to your brain. So some of the things that you'll see is obviously unconsciousness. Someone may do that on the nod, kind of in and out of consciousness before they actually lose consciousness. You may see the bluing of the lips or of the fingertips. That's easier to recognize in people who are light or fair skinned than it is in people who are darker skinned, so that can be an unreliable symptom to try and go off of. Obviously, shortness of breath, rattling sounds while someone's breathing, it almost sounds like a snore, a very slowed pulse, all of those things would be indications that someone is experiencing an overdose. So one of 2 things might happen. You might be just walking through the community and find someone who is unconscious or incapacitated, or you might be in like a party type situation where one of your friends might be using drugs, particularly for like younger, high school, college students, trades. There's lots of people where opioid use is used, we know, kind of disproportionately to the majority of the population. So in those situations, someone might just kind of go down. They might be talking to you one minute, and these drugs are so potent that they can hit very quickly. We oftentimes see that someone will be injecting in the supervised consumption facility, and they will pass out before they've even gotten the needle out of their arm. So the needle hasn't even left their arm, and they're on the floor. So someone might just go down. In either case, the first thing that you're going to do in any of those cases, there's an acronym that's included in your little pamphlet here, and it's the SAVE ME acronym. So it's SAVEME. The first S in SAVE ME is for stimulate. So obviously, if you come across someone in community, you want to make sure that they're actually incapacitated or unconscious and not just start poking them with needles. So you're going to try and stimulate someone. Don't kick somebody, don't scream at somebody. You can, a little shake and try and talk to them. But really the most effective way is to do the sternal rub. So using your middle set of knuckles there, you want to find their breastplate, and you can hear it when you knock on it. It's very hard. And you want to just apply like force. You want to put lots of pressure on, and you want to wiggle back and forth. You're not playing the xylophone, so you don't need to go all the way up and down the rib cage, but you just want to go wiggle back and forth. That, if someone is able to wake up, will wake them up. After you've done that, if they haven't revived, call 911. First and foremost, you always want to call 911. A take-home naloxone kit is only intended as a stopgap until professionals can get there. So you've called 911, then you want to check the person's airway. So very similar to if you were doing rescue breathing CPR. There is also in your kit a rescue breathing apparatus or a barrier that is provided. There is a right and a wrong way to this barrier. It's difficult so that you can see, but you can see there's kind of a more substantial nub on this side, whereas on the other side there's a smaller nub. So there's two ways how to remember which is the right way and which is the wrong way. The first way that you can remember is that the unconscious person needs the larger nub in their mouth because they can't fully close their mouth around it if they're unconscious. You get the smaller part on your side. Additionally, there is writing on this screen on the barrier, and so if you can read the writing, then that's the side that should be facing you. If the writing is backwards for you, then you know that you need to flip it around. The reason that's important is because there's a one-way valve in this apparatus, which means that your airflow can go through, but that if the person vomits or that their spit can't come back into your mouth. So you would just check their airway, lay them on their back, tilt their head up very similar to you would in rescue breathing. If you know the person or feel like you want to, you can check their mouth to ensure that there's nothing that's blocking the breathing tube. However, if you're not comfortable doing that, that's okay as well. You can just do like a visual check. Ideally, we want to make sure that nothing's lodged there so that we know things can actually get back or get through into their lungs. So lay them flat, tilt their head back, and then place this rescue breathing apparatus. You want to make as large a mouth as you can on this thing because you want to create a seal kind of around the person's face. So it kind of is going to look like you're trying to eat their face. Go as big as you can around it. You don't have to blow like you're blowing up a balloon. Really, just the breath that you would naturally release in any given breath is going to be the same amount of breath that that person needs. So we're not like, you don't need to do that, just a regular breath. And it says right on here, so there's stimulate, then airway, and then V is ventilate. So you want to provide one breath every 5 seconds for 2 minutes. This is important. The air is actually more important. The provision of oxygen is more important than the naloxone. Because particularly if I'm providing the intervention by myself and I'm not real comfortable with needles, it may take me a while to get the solution drawn up and to find where my injection site is going to be. And for all that time that I'm kind of fiddling around with that process, that person's not getting oxygen to their brain. If you're not getting oxygen to your brain, then that means that you are at risk of suffering from long-term brain damage, and that even if we bring someone back with naloxone, that if they're then brain damaged once they come back, that obviously, the oxygen is more important than the naloxone. Even if you just do rescue breathing until an ambulance arrives, that's better. However, if you've done rescue breathing for the full 2 minutes, make sure it is the full 2 minutes. If you're not sure, err on the side of caution and go for longer. In emergency type situations, it can seem very much like time is dragging and you can think, oh, surely I've been doing this for 2 minutes, when really it's only been 30 seconds. So err on the side of caution and provide your rescue breathing for even longer than 2 minutes. If you've been doing that and the person hasn't come to, then the E in Save Me is for evaluate. Evaluate the situation. This isn't working. I think I'm going to move on to my naloxone. So the M, so we've done save. In the me, the M is a muscular injection. So I'm going to take these off because they're very warm and sweaty, but let's pretend that I'm still wearing my gloves. In your kit, you will receive alcohol swabs. Those could be used if the person was wearing, say, shorts or their skin was exposed. However, if their skin is not exposed, we're not on Grey's Anatomy, so don't get your scissors out and try to cut through somebody's clothing. Just inject right through the clothing, as long as the clothing isn't incredibly thick. So in the case where someone were wearing, say, Carhartts or snow pants, in that case, you might want to either find a different injection site or you might want to remove the clothing because the tip of the needle has to be long enough to penetrate muscle in order for the naloxone to be effective. And so if the person has very bulky clothing on, then it may mean that only the very tip of the needle is getting in and it's not hitting muscle. So you can use the alcohol swabs if you're able to, but it's not a high priority. So where are you injecting? There's 3 different locations that you can provide the intramuscular injection. You do have to hit muscle, so you might as well go for a place that has a large muscle group in it. There's 3 different options, and I'm going to start with the kind of least effective. So the least effective, or the least kind of ideal option, is right in the deltoid. So that's in the muscle, kind of right at the top of your arm before it meets the shoulder. The good thing about that is it's fairly easily accessible. So let's say that we have someone who's a 300-pound gentleman and it's a 100-pound female trying to provide the intervention. If that person's not accessible because there's some sort of barrier and that's the only area that you can get to, then go for it. That's okay. However, what makes this less than ideal is that it's a small muscle, and so you're not guaranteed to hit the muscle. If it's someone who's extremely overweight or extremely underweight, if they're extremely overweight, then the fat pad may be thick enough that you won't penetrate the muscle, and if they're extremely underweight and emaciated, then you may go directly through muscle and hit bone. So it's an option, but it's not the best option. Second option is right in your buttocks. The buttocks is good because it's the biggest muscle on the body, and so you're likely to hit it. The issues are, number one, that the sciatic nerve runs through one side of your buttocks, and so if you hit that, you run the risk of paralyzing someone. The odds are not great that you're going to, but there still is a risk. And then additionally to that, if someone has experienced sexual trauma in their past, and they come to and are revived, and there's someone's fishing around in their backside area, that may be traumatic and it may escalate the situation. So your best choice is just to go right into the thigh. And I'm going to try and back up. I should have worn lighter colored pants so that you could see this better. But basically at any three of those sites, you want to go in at a 90-degree angle, because if you go in right along the skin or the surface of the body, you're not going to hit muscle, right? You want to go in at a 90-degree angle. And if you've never given an injection, you want to hold it kind of like you're throwing a dart. These penetrate skin very easily, so you don't have to Hulk Hogan it or swing for the fences. You can just really give it a tap and it will go in. You do want to go all the way in. So this is probably very difficult for you to see. I'm reversed here. There we go. Thank you. So the needle, as you can see, there we go, is quite long. And you do want to go in right up to the hilt. So that's where the needle kind of meets this plastic part here. If you're injecting in the thigh, which is the ideal location, then you want to locate roughly halfway between the person's knee and their hip. And you want to do it more on the outer half of the thigh than on the inside of the thigh. So about halfway between the knee and the hip, somewhere along kind of the outer part of the thigh is where you're aiming for. Now, drawing up the solution can be intimidating for folks. I'm going to zoom in here again. So the solution comes in a little vial like that. Perfect, thank you. So this little vial, they're glass, and they are brown, like they're a tinted glass, and that's for good reason. So naloxone is sensitive to sunlight. You don't want to leave this somewhere on like a kitchen windowsill or out on your dash of your car, anything like that. Sunlight will the efficacy of the drug. It won't completely eliminate the efficacy, but it will be less effective. So basically, if you can see on this vial, there's this white kind of plastic topper that sits on top of a metal lid. This white plastic topper just pops off super easily. All that the white plastic topper is there for is to provide this from becoming unsterile. So this keeps the seal sterile. The seal is on the top of it, you can see it kind of looks like a lifesaver. In the middle of the lifesaver, there's like a waxy, plasticky substance, and you want to inject the tip of the needle right through that. So you want a couple things to be careful of. You don't want to go in to the side. If you go in sideways, then you're going to hit the tip of the needle against the inside of the glass, and you run the risk of breaking the tip of the needle off against the glass. So you want to just go in straight up and down at as close to a 90-degree angle as you can get. You can see that's kind of sitting askew. That's okay. Now, a tendency that people have is that they jam the needle in all the way, and then they tilt it up, and they pull on the plunger, and nothing happens. I don't know how well you can see that, but it's not filling up. And the reason for that is that when my needle is all the way inside of this, the tip of my needle, because the fluid falls down, right, because of gravity, the tip of my needle is up higher than the fluid is. So actually, and it's okay if you've pulled this down, you can inject air back into this. It's actually a trick of the trade because it pressurizes the fluid in here and makes it easier to draw out. So you want to, and you can see through this glass, you want to make it so that you can just barely see the tip of your needle inside on the kind of opposite, like above the little metal capper. So then once you have that, you just withdraw, and I'm not sure if you can see that. It is starting to drip in there. You'll see that there's some air in the chamber as well. That's okay. Just pull down and pull down and pull down. You'll see it emptying out of the bottle. You will never get every last licky drop out of this. There will be a little bit of fluid that's left in the bottom of your naloxone vial, and that's okay. So you want to make it so that in the chamber, so you can see that there's some air there and then there's the fluid. So go so that there's as little air as possible in there, but you don't have to be overly concerned about air. You'll oftentimes see on like Grey's Anatomy that the nurses are doing this sort of thing. You don't need to worry about that. It's an intramuscular injection. Even if it was intravenous and you were going straight into a vein, an air bubble has to be about the length of a person's forearm before it's going to do any damage. So you don't have to worry about injecting air into someone. I'm going to not waste this is a demo kit anyways, this won't get used, but just so I don't squirt naloxone all over the library here, I'll insert that back in there. So let's pretend that we have our naloxone in here still. So you would again just kind of hold it like it's a dart and go in at a 90-degree angle into the person's thigh. So I'll show you something neat here. Oh, and also there's 1 cc. So there's 1 cc of naloxone in this. So your needle should pull down to the point that there's a 1 there. Once you have it in the person's body and it's all the way up to the hilt, so where the needle ends there, then you're going to depress your plunger, and you'll hear, when you depress it far enough, you hear a click, and it's called a vantage point needle. So it retracts the tip of the needle into the syringe. People often ask why we don't distribute these types of needles for drug users to use, like intravenous drug users to use, and there is good reason for that. Number one, they're not intended for intravenous drug use, and they actually do quite significant damage to the veins, because if a person is to inject intravenously like this, and then when they depress the plunger all the way, that action of it tearing, like retracting the needle, tears people's veins, causes vein ruptures. People can actually bleed out from that. So that's one reason. Number two, in any syringe, there is what's called dead space in the chamber. So there's a little area where no matter how hard you try, you will never get all of your solution or your drug out of there. However, in vantage point needles, that area is larger than in the other needles that we distribute for injection drug use. And what that means is that users interpret that as losing more of their drug, and that's obviously not something that they're excited about. And so they are resistant to using these types of needles. We did have a pilot project where we handed out the vantage point needles with the intention of introducing them to the injection drug use community, and they were rejected overwhelmingly. People were sharing the other version of needle rather than using this version, the vantage point version, which obviously goes against everything for harm reduction, because one of the primary objectives of harm reduction is to diminish the transmission of HIV and hepatitis C. So you would do one injection. You're not then going to do another and another right away. You're instead going to return to your Save Me acronym. So, and it says that right on here as well. So S was stimulate, A is airway, V is ventilate, then evaluate, M is the muscular injection, 1 milliliter. So that's one of these vials. And then it says evaluate. If you need to evaluate and they haven't come to, and they would fairly quickly, then you would return to the ventilate portion, and you would continue with rescue breathing for another 2 minutes, because remember that oxygen provision is more important than the actual naloxone. So you would do another 2 minutes of your rescue breathing, and then again, if they hadn't revived, then you would move to your second dose. If after the second dose they haven't had a response, you would continue with your rescue breathing for another 2 minutes through all 3 of your doses. Again, using a new clean needle every time. Things to remember about the naloxone itself and kind of storage of the kit. You want to keep it away from sunlight. It does have an expiration date on it. Generally, it's about 2 years from when you are distributed your kit. And then lastly, it is very much temperature sensitive. So, and which is unfortunate, because a lot of people's inclination is to keep their naloxone kit in their car. But unfortunately, that's not a good idea when we live in Canada, because temperatures can swing so wildly. You want to keep your naloxone between about 5 degrees Celsius and 25 degrees Celsius. So, and again, it's very similar to sunlight, that if it's outside of those temperatures, it doesn't necessarily mean that it's completely ineffective, but it will certainly decrease the efficacy of the medication. If you have a kit and you lose it, or it has expired, or it gets stolen, or whatever, you can go into any pharmacy or into ARCHES or any harm reduction organization, and they will give you a new kit. It's free of charge. If you have questions and you want to go through this in person, you want to practice drawing up the solution, that sort of thing, my recommendation would be that you would come to a harm reduction agency rather than pharmacy, because it's not a pharmacist's primary focus. Not a criticism of pharmacists, they just don't have the time to sit down and give you a 20-minute training on how to use the kit before they give it to you. And so if you're not very familiar with needles, it can go a long way to make you feeling more comfortable if someone's actually able to sit down with you and drop the solution and inject it into an orange and that kind of thing. So I would recommend if that's your situation, that you would come into a place like ARCHES in order to get your kit. We don't monitor your kit. I've sometimes, especially when the opioid crisis was first hitting, people had questions about, you know, is my information going to go to Alberta Health in terms of that I've gotten a kit? Because again, the stigmatization and shame of drug use is so much that people who were, say, nurses or teachers didn't want the assumption being made that because I got a take-home naloxone kit, people will now think that I'm a drug user. That's not the case. I would recommend that everyone have a take-home naloxone kit. It may enable you to save a life when otherwise you weren't able to. It's no different than having first aid training or, you know, rescue breathing, CPR type training. Yeah, that's the basics of a take-home naloxone kit. We can give multiple kits as well if it is someone who identifies that they are or have a friend or family member who is a drug user, because that increases the likelihood that they will need to use their kit and need more than one kit.